Streptococcus canis infections in our companion animals are really not limited to a particular site. In kittens, we tend to see respiratory, skin and soft tissue infections, as well as abscessation. And in dogs, it's really an opportunist. Wounds, potentially the urinary tract, it can cause mastitis, etc. Just like in horses, penicillin is our treatment of choice. Strep canis is occasionally associated with necrotizing fasciitis and toxic shock syndrome due to phage-mediated superantigens that are expressed following exposure to fluoroquinolones. So choice of antimicrobial therapy is actually very, very important when treating a strep canis infection in a dog. So the way that this works is here we have our Streptococcus canis, some strains, have an integrated lysogenic phage within their DNA. So the phage is just hanging out, it's not doing anything until the organism is exposed to fluoroquinolones. The fluoroquinolones act by interfering with DNA metabolism, and this triggers what's called the SOS response in the bacteria. When the SOS response happens, we get de-repression of the phage and initiation of the lytic cycle. So the phage goes from lysogeny to the lytic cycle. We get phage replication, and ultimately it bursts the streptococcal cells. Now, this phage is able to act as a superantigen, so it interacts with a large proportion of T cell receptors in the host. When we have all those T cells stimulated, we get a massive release of cytokines. This sensitizes the animal to gram-negative endotoxin. We get complement activation, coagulant activation, capillary leakage, hypotension, shock, and ultimately death. So this is a very serious potential outcome, and a great reason to avoid the fluoroquinolones if ever you suspect a patient having a strep canis infection. Streptococcus suis in pigs is a cause of meningitis, arthritis, septicemia, and sudden death. It has a very high case fatality rate, although if caught really early, treatment may be effective. We typically see disease in nursery pigs, so younger animals, but any age can be affected. Strep suis infections are associated with moving pigs, overcrowding, and poor ventilation, so stressful conditions. And the pigs are thought to acquire the organism from the sow and the environment at farrowing. The bug enters the nostrils, and if it causes an infection, it's thought to do so by entering the tonsils. Here we can see some pathologic tissues from a pig with strep suis septicemia and endocarditis. What I want to highlight here is that we have a discolored snout, so it's cyanotic, as well as the ears. It's this dark blue-purple color, which is a classical sign that you would see in sepsis. Streptococcus suis is grouped by serotypes. As the word serotype suggests, it's about interaction of antibodies with the cells. At present, there are 33 serotypes of strep suis identified. Zoonotic infections are primarily associated with serotype 2. And the people who are at greatest risk are obviously those with animal contacts, so pig farmers, veterinarians, abattoir workers, meat inspectors, and butchers. Symptoms of strep suis infection in people are high fever, malaise, vomiting, eventually meningitis, toxic shock, and coma. There have been some big outbreaks of strep suis infections in people, with the biggest occurring in 2005 in China, involving 206 cases and 38 deaths among pig farmers. This organism usually enters the body through cuts and scratches, but entry through the nasopharynx or the gastrointestinal tract is also reported. Streptococcus bovis is a group D strep, which is easily mistaken for Enterococcus or virulence strep on the plate. This is an organism that's actually included in some probiotic cultures, so it's one that we frequently don't associate with disease. But if you do isolate it from a suspect infection and you have clinical evidence that there is an infectious process going on, you should believe it. It's been isolated from a wide variety of infections in people, as well as opportunistic infections in dogs and cats. Its biggest contribution to disease is probably the role that it plays in rumen acidosis in cattle, so grain overload. The pathogenesis of grain overload is a great model disease for bringing together anatomy, physiology, cell biology, microbiology, and biochemistry. Streptococcus bovis is a lactic acid producer, and we see increased production of lactic acid when cattle eat highly fermentable diets. Now, what happens when cattle get too much of this highly fermentable diet is that the other organisms within the rumen microbiota, can't metabolize that lactate efficiently enough to keep its level within homeostatic parameters. As lactic acid builds up, the rumen pH falls below 5, killing other organisms, and the high lactate concentrations in the rumen then cause water to osmotically flow in from circulation, resulting in systemic dehydration. We then get absorption of lactate systemically, leading to a metabolic acidosis. We see a chemical rumenitis, leading to physical damage, which allows organism translocation into the portal vasculature, and ultimately hepatic abscessation. Finally, we're moving on to Enterococcus. In poultry, this is associated with mortality in chicks, and we see it when we have fecal contamination of the eggs. Remember, Enterococcus is found in the intestine. In acute disease, we see septicemia, so the chicks are depressed, they have ruffled feathers. In some cases, you may only find dead birds. The first sign, it can be death. In subacute to chronic presentations, depression, loss of condition, and pyrexia can be observed. Management is really the key factor in dealing with enterococcosis in poultry, preventing stress and other diseases, particularly other immunosuppressive diseases, and ensuring that the barn is cleaned and disinfected. You can treat individual animals with antibiotics if caught early, but it must be based on susceptibility test results. In dogs and cats, we can see opportunistic infections similar to what we would see in people, so potentially nosocomial infections. Most commonly, we see systemic infections, so bacteremia and endocarditis, or localized infections in the abdominal cavity, genitourinary tract, soft tissue, or the respiratory tract. One particular species, Enterococcus here, has been associated with GI infections in dogs and cats, and actually diarrhea. Antimicrobial resistance, both intrinsic and acquired, can be a big challenge with Enterococcus and frequently affects therapeutic selection. Enterococcus species are commonly isolated from urine, but it uncommonly causes urinary tract infections. These are cases that in people would be described as subclinical bacteriuria, and they do not warrant treatment. When interpreting the significance of Enterococcus cultured from the urine, the first question you need to ask yourself is, are there clinical signs consistent with an infection? A positive culture on its own is certainly not diagnostic. As far as samples to collect, in cases of mastitis, you want to collect milk. In dermatitis or superficial infections, swabs, pus, exudates. If you have dead animals or cases of sepsis, collect the whole animal if that's possible. For pigs who have died of strep suis, culture of the brain is a great way to identify meningitis. And for respiratory tract infections, samples collected by a transtracheal wash. Strep are susceptible to desiccation, so these are organisms we're going to have to be a little bit delicate with. The swabs need to be sent with transport media, and I would recommend contacting the lab for which preparations they recommend. Enterococci, on the other hand, are generally pretty tough. And of course, as usual, you do not want to freeze samples, with the exception of milk. Streps and enterococci will be easily grown using standard culture methodologies. Most will reliably grow on blood agar. Some do better on chocolate agar, which doesn't actually contain chocolate. It's actually blood agar, which is prepared in a different way. So typically blood is added to the molten agar after it's had a chance to cool down. In the case of chocolate agar, the blood is added while the agar is still hot, and so we get lysis of all the erythrocytes. For some organisms, growth may be improved with a CO2-enriched atmosphere, and it may take up to 48 hours, so they can be somewhat slow growing. There's a wide variety of commercial biochemical test panels available, such as the API strip, which generally does a good job, but some species are difficult or impossible to identify biochemically. MALDI-TOF generally provides reasonable resolution, although it can be problematic for identifying viridans streptococci. These include species which lack the Lancefield antigen, so you won't have any agglutination reaction, and Streptococcus bovis can also potentially pose a challenge for MALDI. Nucleic acid amplification tests, plus sequencing, so the CPN60 gene, SOD-B or RPO, provide higher resolution. And then strain typing in the case of a strep suis infection may also be desirable. This is a specialized laboratory test, which may need to be referred out from most diagnostic labs. Zoonotic transmission is really important to keep in mind when considering the streptococci. Strep suis is primarily associated with pig contact. It's primarily serotype 2, and the diseases we're concerned with in people are toxic shock syndrome, meningitis, sepsis, and deafness on recovery. So very, very serious. Strep equi, subspecies zooepidemicus, has been reported in people transmitted from dogs and horses, as well as those who have drunk unpasteurized milk. Strep canis infections in people are less well recognized, although transmission from dogs may also occur. When treating Enterococcus species, you must have susceptibility testing and you must have a species level ID. In the next slide, I'll show you the intrinsic resistance table that really highlights this. For treating strep canis, never, never, never use a fluoroquinolone. Remember that phage-mediated toxic shock syndrome. Streps and enterococci don't tend to produce beta-lactamases, so potentiated penicillins, like amoxicillin with clavulanic acid, a beta-lactam, beta-lactamase inhibitor combination, offers no advantage over amoxicillin on its own. So if you see amoxicillin resistance on your susceptibility test report, you probably need to reach for another class of drugs. And then finally, like I just mentioned, intrinsic resistance is very, very important in enterococci. All Enterococcus species are intrinsically resistant to cephalosporins. They possess a different penicillin binding protein in their cell wall, which cephalosporins have a low affinity for. So never, never, never use a cephalosporin for trying to treat an Enterococcus. Enterococcus faecium is also intrinsically resistant to the penicillin aminoglycoside synergy that we mentioned in our antimicrobials lecture. And then I think it's also important to be aware that some species of Enterococcus are intrinsically vancomycin resistant. So specifically Enterococcus gallinarum and Cassia flavus. And so in these cases, vancomycin resistance does not constitute a VRE, one of those superbugs that we're really concerned with. These are normal gallinarum and Cassia flavus. We're concerned with vancomycin resistance, particularly in our fecalis and faecium. Have a few new terms for today, and of course, some questions for self-assessment.